So, good evening, good morning, and good afternoon to all those who could take time to join today on a very important topic, that is how to approach patient with dry eye. And I thank Cybersight for giving this opportunity. Myself, Dr. Lakshmi Kuniyal, and I am a practicing retina and phacosurgeon at Mathura, which is in India. So now, before I start with this webinar, I'm going to put a question in front of you all. That is, how often do you deal with patients suffering from dry eyes, whether you see it every day, few in a week, few in a month, or hardly any? So I would like to see your answers. What is your daily count of patients you come across in your clinical OPD? And I hope that at the end of this webinar, I am able to make some changes in the thought process which we all share. Oh, that's wonderful to see. So most of us are dealing with the patient suffering from dry eye, that too it's an everyday scenario for all of us. Now, why this topic has become important for us, there was a time when it was these kind of patients were mainly seen by the patients who come across in the either comprehensive OPD or were seen by the ocular surface surgeons. But now, as the time has passed, this topic has become equally relevant for us being retina surgeons, or maybe if you're dealing with a cataract surgery or maybe a refractive surgeon. So I think this topic has become equally important for all of us. So let's start with the topic now. So as dry eye disease, the name suggests, it's a condition of rising prevalence that is also a source of rising frustration for its chronic sufferers. Why? Because it is often misdiagnosed, is undiagnosed, or undertreated. Now, it's a multifactorial disorder of the ocular surface that is marked by a loss or disruption of tear film homeostasis, which is being initiated by dysfunction in one or more ocular structures, which may include the lacrimal glands, meibomian glands, cornea, and conjunctiva, which ultimately lead to tear deficiency and subsequent tear film instability, hyperosmolarity, and ocular surface damage. So you can see it's a multifactorial disorder which is affecting almost all the parts, which are ultimately leading to an impaired tear film production. Now, it is commonly seen in females and is more prevalent in old age. The prevalence in India ranges from 18.4% to 54.3%. DED, as often we call it, often decreases the quality of life and interferes with activities of daily life, such as reading, watching television, work-related tasks, and quality of sleep. Now, looking at the classification in the year 2017, the Tear Film and Ocular Surface Society Dry Eye Workshop 2 classified DED into two types. One was aqueous deficient and other was evaporator. Now, let's see what these mean. Aqueous deficient DED, it affects the lacrimal glands, with its hallmark feature being the inability to produce tears. Whereas in evaporative type, it occurs due to increased tear evaporation and encompasses both lid-related, which include MGD, and blink-related abnormalities, and other being ocular surface-related, which include mucin deficiency or contact lens wearers. About 60 to 80% of dry eye disease is evaporative in nature, and that is important to note. Now, looking at the pathophysiology of dry eye, the lacrimal glands, meibomian glands, cornea, and conjunctiva, they together produce the tear film. A healthy tear film is about 2 to 5 microns thick and comprises a mucin aqueous layer that is rich in fluid, soluble factors, and mucin, which is covered by a thin outer lipid layer. Now, this lipid layer, it serves as an interface between the aqueous layer and the air, and it functions to prevent evaporation of the aqueous component of the tear film. Now, in evaporative type of dry eye, this dysregulation of the tear film composition and subsequent disruption in homeostasis gives rise to evaporation, which exceeds the tear supply. This initiates a cycle of tear film instability and hyperosmolarity, which further perpetuates inflammation and ocular surface damage. In some cases, stimulation and damage to nerves also contribute to this factor. MGD, or we call it the meibomian gland disease, it plays a well-established role in evaporative type. The MGD glands, they produce meibum, which is a critical component of the lipid layer of the tear film, and we know this lipid layer film is essential in maintaining the tear film integrity. The prevalence of MGD in India is from 30 to 55%. Now, this is a very interesting diagram. Please have a look at it. Now, here you can see the pathology is going in two different circles. So here you see when the meibomian gland, it's get blocked or dropped out or get inflamed, there's a lipid layer deficit. Now, when there's a lipid layer deficit, the outer protection of the tear film has gone haywire, which leads to increased evaporation and increase in the osmolarity levels, thereby increasing the inflammation and ultimately leading to the keratinization of meibomian gland orifice. And again, it leads to meibomian gland blockage, dropout, or inflammation. So that's one cycle which is going on. But when again we look at the outer circle, we find the pathophysiology, if we talk about the MGD or the meibomian gland dysfunction, there is a proliferation of the organisms which may lead to blepharitis, like staphylococcus or demodex, which are the causes for blepharitis, happens because of the gland blockage or the inflammation or the dropout. This leads to release of lipases and esterases, and the meibum which is being produced is of compromised quality, which has increase in the melting temperature. Now, because of which what happens, again, the glands, they get blocked, and that cycle, it keeps on going. So you can see that how the pathophysiology is working at two different levels, which is ultimately leading to the dry eye disease. Now, talking about the prevalence, we have already said that it's commonly found in females, and the prevalence increases as the female reaches the menopausal age. We'll see why later. It is more prevalent in patients who have undergone cataract surgeries, who have undergone refractive surgeries, young patients with significant screen time, I think, which has become a kind of a pandemic among us because of a lot of screen time usage, which we all have. The other category is being the contact lens wearers. Please carefully look at this slide. Now, this slide mentions about the risk factors. Now, risk factors, they can be categorized into two categories. It can be non-modifiable or it can be modifiable. Now, why we have made these two categories? Because when we are going to move on to the management part, the treatment part, we have a better control over modifiable risk factors compared to the non-modifiable one. So, modifiable factors, they include computer usage, contact lens wearers, HRTs or hormone replacement therapies. If you're living in an environment which is too polluted or which is arid or is having low humidity, or if the patient is on medications like antidepressants, anxiolytics, or antihistamines, if the patient has undergone refractive surgeries or cataract surgeries, if the patient has a tendency to develop allergic conjunctivitis, maybe on perennial basis, if the patient is a smoker or alcoholic or has a poor lid hygiene. So these are the modified risk factors where we can actually talk to the patient and we can help them to modify, and we can decrease, we can work on the preventive therapies by working on these risk factors. Whereas, or the other category is the non-modifiable one, so where we don't have much control, like you can't work on aging, you can't work on gender, race, MGD if the patient is having Aarogyam syndrome or connective tissue diseases. The probable non-modifiable risk factors include diabetes, some infections, viral infections, rosacea, thyroid diseases, psychiatric conditions. So these are the non-modifiable ones. So whenever we talk about the management for any disease, it is always divided into two parts. It has divided the diagnostic part into the 4 steps. First will be triaging. That means we want to see actually whether the patient who has stepped into a clinic is actually suffering from dry eye or not. So we'll be triaging those patients with the help of a questionnaire, which we'll be seeing in the next slide. Second, we will be working on the risk factor analysis, which we've just discussed about the non-modifiable and the modifiable one. And we know that we have a better control over the modifiable risk factors. The third would be the diagnostic test, and ultimately with the help of these will be coming for the classification whether the patient is suffering from evaporative or aqueous or a mixed type. So the first step is questionnaire. Now this questionnaire comes in the form of ocular surface disease. Now it's interesting to note that how beautifully this questionnaire has been created. You can see here that it comprises of 3 different parts. So the first part is actually deals with the symptomology, that whether a patient is suffering from the symptoms of dry eye. So that includes whether the patient's the eyes are feeling gritty, whether the eyes are painful or sore, whether the patient is suffering from blood vision or poor vision. So that is the first part of the questionnaire. The second part of the questionnaire, it sees whether your daily life works are limited, whether your work or lifestyle is limited or not. So whether you have issues during reading or driving at night or working with a computer or watching TV. The last part tells whether you are living in an environment which is contributing to further aggravating your problem. So we're talking about the risk factors, whether you're living in a windy condition or in a dry area or you are using too much of air conditioning. So here we can see that there are 5 options in each of these categories, which goes from all of the time to none of the time. So let's see that how, based on these ocular surface disease index, the questionnaire which we give to the patient, how we are going to assess the patient. So comes the role of scoring. Now, how the scoring is done. Now, each question is answered on a 5-point Likert scale where 0 stands for none of the time and 4 stands for all of the time. So patient is given this questionnaire and he marks all these questions. Then ocular surface disease index, or we call it the OSDI score, that is calculated by summing the individual question scores. You multiply that sum by 25 and you divide it by the total number of questions answered. So what do you get? Now let's interpret that scoring. The final OSDI score, it can range from 0 to 100. If the score falls between 0 to 12, we consider it normal. If the score falls between 13 to 22, it indicates mild dry eye. If it is between 23 and 32, it suggests moderate dry eye. And if it goes 33 to 100, it indicates severe dry eye. So this questionnaire has helped us to understand from symptomology to the risk factors to how that the condition of dry eye is actually affecting your daily lifestyle. Along with that, scoring has also helped us to categorize whether the patient is having from mild, moderate, or severe dry eye. So that's the first step we have crossed. Now, moving on to the second step, that is the analysis of the risk factors. So this is the same slide I'm repeating again. As I've said before, we have to work on modifiable risk factors because we have a better control on them. So if the patient is an avid computer user, you have to counsel the patient to limit the use of screen. He judicially use the screen system. He should not overdo with the screen usage. If the patient is a contact lens wearer, you again have to counsel that this is going to increase your risk factor for their dry eye. If the patient is on hormone replacement therapy, this actually helps because if the patient is in the menopausal stage where the level of the estrogen and the androgens they're coming down, that enhances or that pushes the females to have a high risk factors for developing the dry eye. So basically HRT helps, but that is usually not recommended only for the dry eye. If the patient is on antidepressants or anxiolytics or antihistamines, again, you have to tell the patient that if you're taking them on a long term, you have a high propensity of developing the dry eye disease. So that is, you have to counsel. You have to tell the patient to have a healthy lifestyle. So stay away from smoking, stay away from alcohol, have a good lid hygiene, because if there's dermatitis infestations or you have a staph infection, that is definitely going to add to the problem of dry eye disease. Besides that, if the patient is having surgery, also of dry eye issues. Now, before moving to the next step, this is a very interesting slide, which I just got when I was going through the this. See, I said when we talk about the dry eye, we always have to see the local factors which may be contributing to the development of dry eye. You just only don't have to only keep looking towards the signs, maybe on the slit lamp or maybe on the symptomology, but you should not miss onto the part of the surrounding lid area or the local areas which will be contributing. So when we talk about look, it involves examining the face and eyes for rosacea, watching for the occurrence of incomplete blinks or exposures, and looking at the ocular surface, lids, and lashes. So if you look for the incomplete blink, like maybe in a patient of Bell's palsy, the patient is not able to completely close the eyes properly. So that again going to push the patient towards dry eye. If the patient is having poor lid hygiene, so look at the lid lashes, look for the eye hygiene, because that's causing the blepharitis, was again going to push the patient towards dry eye. Second comes lift. Now, lift involves lifting the upper lid to examine the superior cornea to rule out keratoconjunctivitis and corneal dystrophies. So if you remember, when we're talking about the risk factors, we said if the patient has a propensity to have a allergic conjunctivitis, then these patients, they have higher risk factors of developing dry eye. Same way, when you lift, just look for that you may be missing onto the allergic conjunctivitis or keratoconjunctivitis. Don't lift the upper lid and may miss on this finding too. Now, pull the upper lid to test for lid laxity. So whether the eyelids, they are working properly, whether the mechanism which is involved for the proper lid drainage, that is there or not. The push step, it involves expressing the Meibomian gland to evaluate the quality, quantity, and flow of this. Is going to help you to look more deeply into the presence of any MGD dysfunction if it is there. So that's a very important slide, I would say, to remember, to look, lift, pull, and push. Now we come on to the diagnostic test, which we all perform in our clinical setup. So the primary test which we all do is, we call it the Schirmer's test. Now this Schirmer test, it assesses the tear production. Now this test is based on the concept of capillary action, and it involves placing the test strip in the eye for 5 minutes and observing the length of wetting on the strip. Now, as you can see here on the picture, that the strip, there's a Schirmer strip, which we call it, that is usually placed into the outer 1/3 of the lower lid in the cul-de-sac. You can place it anywhere, but that becomes convenient for you to place it over there. Now, when you look at the reading of the wetting greater than 10 millimeters in 5 minutes, then absolutely the patient is normal. You don't have to do anything. But if there is a score of less than 5 millimeters in 5 minutes, the second test which you do is the vital dye staining. Now, due to increased shedding of the epithelial cells in the cornea and conjunctiva, in patients with dry eye disease, there is a loss of protective glycocalyx barrier. Now, the underlying new cells, they can thus absorb the vital stains. Now, vital stains include your sodium fluorescein, you have rose bengal, you have lissamine green. That's 3 important dyes which we use commonly in our clinical setup. So, the degree of staining, that correlates with the severity of the disease. Now, you can see on the left that how the eye looks when you stain the eye with the rose bengal, and right hand side you have the eye stained with lissamine green. Now, when you look at those pictures, like I'll just repeat the slide again, by look at of this, I think it will be difficult for us to say whether the patient is suffering from mild or moderate to severe, first thing. And secondly, it will be difficult for us to have a inter-observe variation, because see, it may happen that you're working on a team and someday I see the patient and someday my other colleague sees the patient. So if we are not on the same term, then it becomes difficult for us to assess the result of our treatment. So we wanted some scoring system so that it helps us, all of us, to be on the same platform. So moving on to the scoring system. Now, we had earlier the scoring system by the name of Van Bidsworth scoring system. Now here, as you can see, it was the eye was divided into 3 sectors: your nasal and your temporal and your central cornea. So the conjunctiva was stained with lissamine green and the cornea was stained with fluorescein. So how the scoring was done: if there was no spots, it was considered score 0. If it was sparsely scattered, we call it score 1, densely scattered 2, and confluent spots 3. So overall, the maximum score came out to be 9. Now, what was the problem with the scoring system? Same as I said, if you're working on a team and if I say, suppose the patient is having score 1. Now, it may happen that for me, sparsely scattered will be something different. The terminology for you for a sparsely scattered may be a little different. So again, we are not on the same platform. So it will be difficult for us to assess the treatment. right? And it may happen that you may forget next time if you see the patient. So we needed something concrete where we are sure that we can calculate, we have some number system, and it is easy for us to reproduce the results which is there. So because of which the other scoring system came into play, and that was the ocular staining score system. Again, the conjunctiva was stained with lissamine green and the cornea with fluorescein. But here, if the stain dots were from 0 to 9 was seen, it was graded 0. It was from 10 to 32, it was graded as 1. Between 33 to 100, graded 2. And more than 100, it was graded 3. Same for the cornea. If there were no dots, it was 0. From 1 to 5, grade 1. 6 to 30, grade 2. And more than 30, grade 3. So here, see, you can see that it's easy for you to calculate the number of dots for you and for anybody else whatsoever. So here again, the maximum score came out to be 9. But if the patients, besides these dots, if they were having patches of confluent staining, then we have to add +1 to it. If there was staining seen in the papillary areas, we'd add again +1 to it. And if there was filament seen, we'll add +1 to it. So it was increasing onto the severity level. So the maximum scoring system in this would be around 12. The other common test which we perform in our clinics is the tear film breakup time, or TBUT as we fondly call it. A TBUT test, it evaluates the stability of tear film. Now, tear film breakup time is the measurement of initial breakdown of tear film, or the time it takes for a dark spot to appear in the fluorescein stained tear film since the last complete blink. So as I think everybody knows that how we're supposed to perform this test, we stain the eye of the patient with a fluorescent strip, and we instruct the patient that when we'll ask you to look towards the light, and we examine such eyes under cobalt blue, right? So we'll ask the patient not to blink the eyes whenever I'm going to focus the light on your eyes. So you have to keep staring at the light. And we will look for the first dark spot. That means from where the tear film has started breaking, it will appear as a dark spot because now the staining has gone from that area. So we'll look for that first dark spot to appear in that fluorescein stained tear film since the last complete blink. So that is how we're supposed to do a TBUT test. And that is usually done in a dark room or a dimly lit room. Now, if a TBUT of less than 10 seconds is there, then it indicates tear film instability, and a measurement of less than 5 seconds is considered a diagnosis of dry eye disease. TBUT test is also a good tool to monitor DAD status and response to treatment. So that is when you initiate the treatment in such category of patients, that definitely TBUT helps you to see that how the patient is improving, how the stability of the tear film has improved as we have started the patient with the treatment. So that is again one of the good monitoring tool also. So here again, if it's more than 10 seconds, you can see all these dark spots. These are the patchy areas from where the stain, the tear film has started breaking up. It starts showing itself as a dark patchy spots. So if the time taken is more than 10 seconds, it's normal. If it's between 7 to 10 seconds, we classify it as a mild. If it's between 5 to 7 seconds, we call it as moderate category. And if it is less than 5 seconds, it points towards a severe category of dry eye. Now, tear volume measurement, that is also one of the tests which we perform in our clinic settings, and this is done on slit lamp. Again, you do it on a dark room or a dimly lit room. You again stain your tear film with the fluorescein, and you use your slit and you decrease the height of the slit to measure the height of the tear film. And normal the tear film height is 0.2 to 0.4 millimeters. The tear volume, it is assessed by measuring the inferior tear film meniscus height. That is how you do it. Now, osmolality test. This is one of the tests which I would say is highly reliable. If you talk about all the tests that are of all the tests, if you ask me that which are the diagnostic test, which actually, if performed, is going to label the patient that he is or she is suffering from dry disease, and that is the osmolality test. Now, tear sample is collected to assess for osmolality, and a osmolality value greater than 315 is considered to represent mild to moderate dry disease, whereas a value of 336 is considered to be severe dry eye disease. Besides high levels of osmolality, it microgram per ml or more of MMP9 is detected. So you have a combination of two. You have a combination of high osmolarity and the presence of metalloproteinase 9 that has proven to be successful in identifying diseases in patients, even if they are asymptomatic. So that's why I said, like, it is the diagnostic test. Even if the patient are not present to you with symptoms, we can definitely identify the patients who have a very high risk of developing dry disease. But the problem with this test is that it is not easily accessible in the clinic. So usually at your high centers or maybe at your research centers, these tests are available. So for your regular clinics, you may not have access to this test. So we have all spoken or done with the test which we do in our clinics. But besides these, we also have certain diagnostic devices which either help us to suspect the patient may be suffering from this, or to quantify the damage of the glands in these patients. So the first being the placido disc corneal topography. So if on the slit lamp you have evaluated the patient and you don't find any corneal lesion, then presence of any irregular topographic pattern which is persistent in between the test, then that is an indicative of dry disease. That means the surface is irregular despite the absence of any corneal lesions. That means the tear film is not retaining its shape, it's breaking up. The corneal irregularity is there because of your tear film instability. So that is one of the tests which basically urges you towards screening the patient for dry eye disease. Meibography, I think everybody has heard of this. So this is one of the diagnostic devices which, besides using for diagnosis part, you also use this device to look for the response of the treatment. So you know that if the patient is having normal meibomian gland, they will appear straight and aligned, but abnormal glands appear tortuous, dilated, congested, or atrophied. So as you start the treatment, you can see the tortuosity and dilation that it just starts lessening down as the patient starts responding to the treatment. But yes, the gland loss that usually remains the same; it doesn't gets reverted back. So in the previous slides, I have discussed about the first part of the management, that is the diagnostic part, where we have assessed the patient. We suspected the patient of dry eye. So we wanted to know whether the patient is actually suffering from dry eye or not. So we have a list of questions with us. So we assess based on that. We again classify the patient based on that, whether the patient is having mild, moderate, or severe. Then we went on to the risk factor analysis, where we talked about the modifiable risk factors because we have a better control on them. Then we moved on to the diagnostics test on the clinical setups, which we commonly perform the Shermers, the T-bits, and we do vital stainings. And in research areas, we do osmotic tests, we do a tear film volume assessment. And we also have a diagnostic devices with us, like if you have access to the meibography. So this all has been done to move on to the second part of the management, that is the treatment part. So I'll be taking up on this treatment part in my next webinar, because it'll be again a full-fledged discussion, because we have a lot of the new things, new trends besides the conventional treatment they have come up, which caters with not only with the severity, which also deal with the type of the dry disease the patient is suffering from. So based on the information which I've gathered so far, so let's look at this flowchart. So a patient has presented to you in the OPD. The patient can be asymptomatic, patient can be symptomatic. So if the patient is symptomatic and you see the signs of ocular surface disease or dry disease, I think it becomes a straightforward thing for you. Follow the flow chart. You have to start asking the questions. You have to start looking for the modifiable risk factors. You have to move on to diagnosis test and start classifying and start the treatment according to the final diagnosis which you made. So that's a straightforward. But you may have a category of patient where they are symptomatic, but you don't find the signs in them. So if you don't have the signs, so it may be that patient is still in a preclinical stage. So they have still not developed signs, but because they are complaining, so that means they are in the verge of developing. So you have to focus more on the preventive therapy. So here again, we have to see observe the patients and look the modifiable factors, work on them, because that's going to work in your. It may happen that patient may be having neuropathic pain because some other causes, and because of which patient may be symptomatic. So in that condition, you can refer the patient for pain management. So the other category is asymptomatic, which I think is more of a dubious condition. So if the patient is asymptomatic and on examination you don't find any signs, so it becomes a straight thing of, okay, the patient is normal, you don't have to treat the patient. But if the patient is asymptomatic and you see signs of ocular surface diseases, so you have a category patient, there are signs without symptoms. So that means patients are predisposed to the dry eye because you can see the signs. It has started manifesting in the eyes, though patient may not be aware of the symptoms, right? So again, you have to work on the preventive management as well as the appropriate therapy. So it may happen, specifically patients who have undergone refractive surgeries or may have undergone cataract surgery, it may happen with them. The other condition where the patient is asymptomatic and you find signs of ocular surface disease may be neurotropic. So if you remember, we said like pull, push, that slide algorithm. So patient may be having problem of like Bell's palsy. So where the lid is improperly closed or lid laxity is there, that improper closure is maybe leading to more of an evaporation of the tear film. So in that condition, you have to treat the patient according on that particular scale. So overall, it is important to remember that this gives an overview that how you're supposed to approach to a patient who has presented to you in the OPD with the complaints, maybe symptomatic, asymptomatic, and this is how we're supposed to move about. But one more important thing I would say, that always remember the dry disease is a spectrum. So it is never like you go to patient, get on one end, maybe aqueous or evaporative. You can have a complete or mixed picture also. You may have a certain percentage of aqueous part, you may have a certain part of evaporative part. So you most of the in clinics we get a mixed type. Then how we categorize, we have already seen. So overall, our whole purpose of discussion and performing so many tests and questionnaires and looking for the risk factors is to overall go for the management to restore the homeostasis. So the second part, I'll be coming up soon, where I'll be discussing about that how we are supposed to treat the patients who are suffering from mild to moderate with a different severity level. So again, I think I'll put up this question again. So I think the answer would remain the same here because uh, is the same. Though I think already you have people have said that you see the patients in every day, because the purpose of putting this question for you all was that because most of the times we miss on diagnosing the patients, because you might have come across an OPD when even doing a beautiful surgery, very, very nice outcome, even if the patient is having vision of 6 and still complains, doctor, I'm still not comfortable, I'm still not happy with the surgery which I've done. So it happens because of the dry eye. So I think you guys have already have answered this question. So thank you so much. The answer remains the same, though I believe that with this, I must have added something to knowledge and a clinician next time. Thank you so much for your patient hearing. So according to ADS, there is a type of DAD called decreased wettability. May I know how you manage patient of this type? See, as I said, you will always have a combined picture, right? So when the patient may have some component of aqueous deficit, patient may have a component of evaporative. So you have to actually see how much percentage of which is contributing more, because there may not be much problem with the aqueous, and patient may be having more problem for the lipid deficiency where the TFM stability is being compromised. So most of them, it has happened that we are working on the aqueous layer and actually the patient is suffering from the lipid layer instability. So we have to see that which portion is contributing more to the patient problem. But rest of the management, how we're going to move, as I said, I'll be coming with the next webinar, which I'll be talking about detailed that how we're supposed to move with the treatment in these category of patients. Thank you so much, Yadra, for this. I'm happy that you could get information out of these slides. Shafkat has asked, is the mammography done with a machine? Yes, it's a machine where This machines basically help you to diagnose. As I said, if it's a normal glance, you see them straight, they are not dilated. And if the patient has got MGD or meibomian gland disease, then because of the mebum, which I said, if one of the slides have mentioned that the temperature of that mebum which is produced increases, so it doesn't liquefy easily. So it clogs the glands. When it clogs the glands, it dilates and it makes it tortuous. So you on this machine mammograph, you can see the dilated and tortuous glands if the patient is suffering from MGD. Besides that, you also use it for the how the patient is responding to treatment. So if the patient is responding nicely, those tortuous dilated glands they start becoming towards the normal straight one. OSDI definitely it's a more accurate as far as the question is concerned. I'm suffering from pure keratoconjunctivitis, but I still am not using lubricant cornea shape possible change, but I should do now. This is one of the complications which happens in patients who are suffering from the dry disease. And if the patient has got Sjogren-Reich syndrome, definitely these patients they tend to have usually a severe kind of dry eye disease, and a pure lubrication will not help. So you already mentioned that you are not using any lubrication. So first you have to use you have to use the lubrication depending upon the how much loss you have. The molecules which will be better, I'll be telling you in my next webinar, which will be working better in your condition. But because surface inflammation quite high in the conditions of keratoconjunctivitis sicca, so we have to add anti-inflammatory also. So usually these patients they are on quite long treatment on anti-inflammatory agents and on lubrications. They do well, but yes, it's very difficult for them to keep them off the treatment. How to detect DED due to mucin deficiency? We said the mebum, this is being formed by your meibomian gland. So if we talk about clinically, see, one thing as we said is mebography, but if we talk about clinical, I think I will focus it more on the clinical part. You have you examine the patients on slit lamp. So when the patient is suffering from MGD, you will find that end of the lid margins at your waterline, you will find the clogged orifices of these glands. They're seen as a pearly white dots. So next time when you look at the patient, you just look at them, you will find that little pearly dots, which are actually nothing but the clogged meibomian glands. Do we need to dry the eye with tissue while checking, just like Dr. Sharma's? I think it's a tear film height you're talking about, right? Uh, Yes, you have to, because you have to see that the patient should not be, at the time reflex tearing. So first just relax the patient to wipe out any extra tear if it is there. And then you stain the tear film and then you look for it. But yes, you should not rub the eye at that time. But yes, extra watering should not be there at that time. Do you use lissamine fluorescein stain simultaneously or after 10 minutes? For me, see, for my clinical patients, I use fluorescent stain and I don't use lissamine green much. I use Shermer strip, and for staining part is fluorescent stain, and I use rose bengal. That's what I use in my clinical setup. But yes, if you have to use, just use it after a gap of after 10 minutes, because when you stain, then you have to start looking for the dots. So by the time, if you do it both together, it may get washed off and you may not be able to count the number of dots. Any experience with OCT and OCT of meibomian gland and TFM analysis by OCT? Well, usually OCTs are not usually required for the assessment of meibomian gland. As I said, you can very well look at the amount of that meibomian gland affection with the help of a slit lamp. So you don't need OCT for that. And tear film analysis can be very nicely done. Again, as I said, you can go for the tear film volume measurement by looking at the slit height, as I said, is like from point to point 4. So you can very easily assess on that. So for this, if you have access to OCT, you can definitely do it. But I would say that it is not must for you to assess the tear film on OCT. What will be the treatment for a patient who has dry eye, but also they are irritated to the artificial tear drops? So the artificial tear gives them pain in addition. Well, yes, I have seen the patients who suffer from dry eyes. When you start putting the teardrops to them, they are not comfortable. But yes, initially, because their eyes are super sensitive, no, you must have seen that these patients, they complain a lot of reflex tearing. So if you put something in their eyes, or maybe because this preservative or tear drop per se, or any drop per se, there's going to actually for them work as a foreign body. But once they get regular with the treatment of the dry eye, they definitely start feeling better. But initially, yes, you have to counsel them, and they have to be motivated to continue with their treatment. How we assess Meibomian gland function. So, as I said, you have two ways. You can either assess it on your slit lamp, and more on for quantification purpose, you need Meibogram, where you can assess on the damage done, and you even look at the Meibomian gland loss, which we cannot see clinically. For reduced mucin secretion, what is the treatment? So treatment, but as I said, I'll be talking in the next webinar. So I'll be skipping on this question. Okay, what's the next one? How do you recommend steroids or cyclosporin treatment inflammatory? See, I'll just for whenever you have dry, one of the components which is there is the inflammation. So we have to add any anti-inflammatory or steroid per se to control that inflammation. But usually the mild type, you don't require them. When the situation becomes in the category to moderate to severe, then definitely we have to add to it. And cyclosporin immunomodulator, we have to add in conditions where either the patient has become refractory and not responding to steroids, or if the patient is suffering from immunological disease like in Sjogren or something. How to treat DED naturally? I would say work on the modifiable risk factors. But if you have developed dry eye, then definitely you have to take help of medications. But yes, to decrease the incidence or decrease the tendency to get towards dry eye, you have to work on the modifiable risk factors. Decrease your screen time, stay away from polluted areas, use less of heating elements, use less of air conditioning. So we have just enlisted a number of modifiable risk factors. You have to work on those. Does it cause yellow coloring? Uh, Only dry eye doesn't cause the yellow color appearance in the eyes, but if the patient is having the risk factor of allergic conjunctivitis, then definitely patient may have the yellowness in the color. Because I said one of the risk factors is if the patient is having perennial or the allergic conjunctivitis. So because of which there may be change in the color of the eyes, but dry eye per se doesn't cause any change in the color eye, in the color of the eye. If DED is not treated, then how much chances of being keratoconus? See, if the patient is having only dry eye, then there may be change in your keratometric values, but that per se doesn't lead to keratoconus, right? Until unless this patient is having some immunological cause, which is like in Sjogren, as I said, or connective tissue disorders, which has led patient to have dry eye. In that condition, the pathology is different. But if I just talk about a plain dry eye where there's no immunological predisposition, then these patients, they don't develop keratoconus. So the presence of Sjogren syndrome, connective tissue disorders, or having a severe allergy where the patient is constantly rubbing the eyes, those are the patients who have the chances of developing the keratoconus along with the dry eye. Now, MGD is very common in old population, and they have difficulty in keeping hot compresses in their options. Yes, definitely, as the patient age down, because of in the females, the hormonal changes and other aging issues, the old population they have. But hot compresses, I think why it'll be difficult to keep hot compresses. Well, you have nowadays the micro beads, no, they also come if the patient is not comfortable I usually to my patients tell them to have a maybe hanky or small towel where they can maybe microwave it for 10 seconds, or maybe put it on hot oven, just to make it I think not too hot, so they can apply in the eyes if the patient is not comfortable that way. So you have a microbead, that eye patch it comes, so it can be microwave for 10 seconds, and then you can, according to the temperature, you can accordingly put in your eyes. I think that may be a little easy for the old people. How do you manage a patient with persistent epithelial defect? So, as I said, that this is again one of the complications of patients suffering from refractory type of dry eye diseases. So, these patients may require the presence of contact lenses. So, we give scleral contact lenses where they have a reservoir of no fluid present in front of the cornea, so that helps to actually hydrate those areas, and the friction which is caused, that is also reduced by these scleral contact lenses. So that basically helps to decrease the dry eye, and thereby decreasing the inflammation, and the friction part that's also get reduced, so ultimately leads to the healing of the epithelial defects in these patients. So, does we have to let DED patient use lubrication for life? Well, unfortunately, dry eye disease is treatable. It is not curable, right? So it may happen that if the patient has presented to maybe at moderate to severe category, and with the treatment, patient has landed into a situation where he has only now mild symptomology, and he may be treatment free maybe for a few months, depending upon how well he has controlled his risk factors and how well he's maintaining his lifestyle. But as I said, there are so many risk factors. Since multifactorial disease is, it's practically impossible for you to cure the patient for life. Patient will come back to you some point of life to take the treatment. So I won't say that you have to continue the lubricating for life, but yes, you may have to restart the treatment in between as a situation arises. But if the patient is or maybe has come up with a mild type of dry eye, and he is intelligent enough to understand that how the risk factors are actually has aggravated his issue. So sometimes they do well because they understand the pathology behind it. They improve their lifestyle, they take care of their risk factors, and they do well even at the least of the medications, or even may remain drug free for a quite long time. Is frauding a reliable sign of MGD? Yes, it is, because when MGD is severe, you see that foamy thing at the end of the lid margins. That definitely is a sign of mammalian gland diseases, and along with that, you also see the clogged orifices of mammalian gland on your slit lamp evaluation. Which drops we use in dry eye? Well, it is not. It depends upon the severity of the dry eye, which layer is deficit, and which percentage is contributing more. So I'll be discussing it in detail in my upcoming webinar. Please stay tuned in. Sometimes patients are not satisfied with sustained eye drops. Which medication can be used then? I think we'll come up in the next webinar with a detailed discussion on this. How long will you give steroids to your the patients? Steroids, it, as I said, it's just to control the inflammation. So when the inflammation part has subsided, then you can start wearing off the steroids from the patient's treatment regimen. What are the blood profile tests we need to perform in patients suffering from dry eyes associated with connective tissue disorders? You don't have to perform anything separate for the dry eye patient. It's normally what the physicians, they will suggest your patient to undergo connective tissue disorders. See, that's dry eye in these patients is one of the implications of connective tissue disorders. You don't have to perform something different to diagnose the dry eye in these category of patients. Is there any other medication other than lubrication? But yes, you have so many medications besides lubricants. Even nowadays, the new treatment trials they have come up. So I'll be discussing them in detail in my next webinar. Which is more accurate, the Shermer's test or the tear film profiling? See, if you talk in terms of the accuracy, as I said, the most reliable, most accurate is the osmolarity test, which I said unfortunately is not available in every clinic. But yes, you have a battery of tests like Shermer's, your Tibet, and Tibet, or your TFL volume, which we do. So that's basically all together helps you to categorize the severity of the dry eye in your patients. So it's not a one test, it's a basically battery of tests in total. Do you apply LipiFlow for any D patients, no matter what, no matter with or without MGD? See, LipiFlow treatment is given in the patients when the patient is suffering from MGD. It has got no role if the patient is having aqueous deficiency. So it is done in those patients only. Do you prefer hyaluronic acid or bipanol? I'll be discussing in next because said I don't want to point toward one particular drug as such. As I said, it all depends upon the severity. It all depends upon the which layer is deficit, right? So, what is the hot compressor regimen? Hot compressors are usually given in patients who are suffering from meibomian gland. And why do we give it? I think that's very important for us to understand. We know that in MGD, the glands are blocked and the mebum which is produced is not of good quality because it's not able to express itself out, right? It's got stuck over there. So we want actually, we give hot compressors to patients first to, help the patients to little liquefy that mebum which is stuck in the glands. And we ask the patient to uh, give lid massages. So first, I ask patient to have hot compresses, which brings down the inflammation part, which also raises the local temperature and helps the patient to express the mebum, which is stuck in those glands, with the help of a lid massages. So initial stages when patient is having a good amount of MGD, then you can even ask the patient to go maybe 3 times a day from 1 minute to 5 minutes as the patient is comfortable. As contact lenses contraindicated in dry patient, if as contact lenses contraindicated dry patient, if we use material contact lens can be used. Well, contact lenses, I would say I would use the term contraindicated because if the patient is having mild to moderate, then these patients can be given contact lenses along with the lubricating so as to decrease the discomfort of the patients. Nowadays, even you have contact lenses which have got better water content and better oxygen permeability, so that overall makes patient quite comfortable. But yes, if the patient is suffering from severe type of dry eye, I wouldn't ask patient to go for a contact lens because whatever you do that's actually act as a foreign body and the patient is not quite comfortable. So if patient is having Sjogren syndrome, and there I would obviously not suggest to have a regular contact lens just to improve the refractive error. So if it's a therapeutic purpose of contact lens, that's altogether a different story. Now, what is a role of autologous serum eye drop? That's again one of the very new upcoming treatment which we give in refractive patients. The details I would be discussing in the upcoming webinar. Is changing climate have any effect on rice? Yes, absolutely. As I said, if you are living in an area which is arid, which is dry, and it's quite windy, or if you have to use a lot of air conditioning, or if you have to use a lot of heating element, then it's definitely going to affect and it's going to aggravate the dry issues. And what's the correlation between diabetes and dry eye? Uh, uh, there's not a direct, I would say, correlation, but yes, the patients who are diabetic, maybe the uncontrolled one, or who have a diabetes of more than at least more than 5 years, they have a higher propensity of developing the dry eye issues more. And if the patient has developed glaucoma, maybe secondary to diabetes or otherwise a primary glaucoma, then that also contributes to dry further because of the usage of the preservatives in the drops. So, do patients become refractory to DT treatment? What is done if that is the cause? Yes, you have certain category of patients who doesn't respond well to the usual treatment or the conventional treatment which you give. In those category of patients, we have the newer upcoming treatments in form of serums and your IPL therapies, which I'll be talking in detail in my next webinars. So yeah, I'll be focusing on these category of patients too. If patient have mammalian gland dysfunction and CVTE is performing reflex low latent but mammalian gland will cure it. That's again on the treatment part. So I just don't want to take out the fun from you guys because I would be discussing about all these in my next webinar. We'll have a discussion, detailed discussion about all these. So I've just noted down your questions and queries. So hopefully, I think we'll be connecting again, and I'll be attending to all these questions. Beacon glaucoma drop is the culprit rise. Yes, absolutely. It is the preservatives in the glaucoma drops which we give to the patient, or it's not even glaucoma, I would say any preservative in any category of drop which you give, that has got the side effect of inducing dry eye. And if the patient is already suffering from dry eye, it's definitely going to aggravate the issues. How can allergic conjunctivitis change eye color? See, if you remember of the the dusky eyes, or maybe we call it as a if you've seen the children who suffer from allergic conjunctivitis or vernal keratoconjunctivitis, you must have seen that the color of these children, they are a little sandy or brownish color. So that constant rub, the constant friction which is occurring in these patients, I think that probably leads to the migration of the pigment cells that maybe lead to discoloration. But dry eye per se doesn't cause it. Only if the patient has allergic conjunctivitis, and that too severe, persistent, perennial type or vernal keratoconjunctivitis, usually those patients they have a change in the eye color. I think we are done with all the questions. Thank you so much. I think we'll be discussing the next part of the question regarding the treatment in the next upcoming webinar. I'll be connecting with you soon. Thank you so much, all, for joining today on this. And it was a wonderful session. And again, thank you all who could join in today.